I'm Amy Jenkins, and I am a Research Fellow at Swansea University, Department of Psychology. Today's talk, I'm going to just give you a very brief introduction to a research study called Characterizing Subjective Cognitive Impairment, SCI. I will only give a brief introduction of what SCI actually is, because you can visit one of my previous Age in Bite videos, which will give you a much broader perspective of what SCI actually is. If you can imagine a graph of a progression of Alzheimer's disease, so the progression here. Down the bottom, you have where cognitive impairment reaches the potential of dementia. Just before dementia, you've got an area called mild cognitive impairment, MCI. It's at that point that people tend to find that if they had to do normal cognitive measures in, say, a memory clinic, they're identified as having difficulties with their day-to-day functioning. When looking at dementia, if we were to be able to identify it only by this point, so mild cognitive impairment and dementia, well, there's already irreversible damage in the brain. So surely it seems more logical to start looking a little bit earlier in an area called subjective cognitive impairment. SCI is when a person subjectively experiences cognitive difficulties with, for example, their memory and their thinking skills. Now, we all experience SCI at some point. I certainly do when I'm stressed or I've had very little sleep. But there is a very small percentage of people that may be experiencing SCI at the very early stages of Alzheimer's disease. However, the difficulty that we have with SCI is that we don't yet know what characterizes it properly. Therefore, we don't know how to measure it. And there are so many different causes of SCI. But it does seem more logical to look at SCI rather than waiting until we get to MCI or dementia, because there's irreversible damage there. So if we look at SCI, at least we can try and preserve cognitive functioning at a much higher level. My main study that looked at SCI is looking at the characteristics of it so that we can provide a rationale of what's actually causing SCI and how we can maybe try and remove SCI for those reasons that might be reversible. In my study, we looked at demographic variables. So we looked at education, IQ, age. We looked at general cognition, memory. We looked at both visual and verbal. We looked at mood, anxiety, personality, and mainly neuroticism, and quality of life. Some other cognitive functions that are not usually measured that much when it comes to dementia. Well, not as much as when you look at, for example, most people think of memory when they think of dementia. But obviously there are other cognitive functions, and the main one we look at is attention. So in our study, in this particular study, we looked at visual attention related information processing speed. So we looked at reaction time. And then the intra-individual variability of reaction time as well, because both have also been linked to the characteristic of Alzheimer's disease and mild cognitive impairment. The design of the study was cross-sectional, because this study was part of my PhD. So this cross-sectional study, we looked at males and females between the ages of 55 and 65 years. Everybody in this study were, by their own understanding of good general medical and mental health. We recruited 100 participants, and their mean age was approximately 60 years old. They had no dementia diagnosis, and they had not been to the GP to complain about any difficulties they were experiencing. We had two participant groups. One group were those with SCI, and then the second group, they did not have SCI. They were measured to know if they were in each group by the Cognitive Change Index. There were two main hypotheses. The first was that compared to people with no cognitive complaints, people with SCI will have slower information processing speed and greater intra-individual variability of reaction time. The second hypothesis was, compared to people with no cognitive complaints, people with SCI will have poorer scores on cognition, mood, anxiety, quality of life, memory, and higher scores on neuroticism. The results from hypothesis 1, if we look in between groups, between the SCI group and the non-SCI group, there were no significant results in relation to reaction time and intra-individual variability. But when we looked a bit closer and we looked into the groups, in the non-SCI group, there were no relationships, no correlations with reaction time, intra-individual variability and SCI scores. But when we looked into the SCI group, there were some relationships between reaction time as measured by the Trails Making B test, and there was greater intra-individual variability in the SCI group. But I will need to make a bit of a cautionary note that even though these results were significant, the effect sizes weren't that great, but it does show a bit of a pattern there. Hypothesis 2, so between the groups, when we were looking at mood and anxiety and things, we did notice that between the groups, the SCI group were significantly more likely to have lower scores relating to mood, anxiety, poor quality of life, mainly physical, psychological and environmental, and they had higher scores on neuroticism. Again, when we looked within the groups then, in the non-SCI group, there were no relationships again with SCI and any of those other variables. But in the SCI group, yet again, we've seen relationships, significant relationships between SCI scores, worse memory, worse depression, so low mood, anxiety, poorer quality of life, and higher scores on neuroticism. So what does all of this mean? Well, firstly, I have to say that if you look at the distribution of the SCI scores, those in the SCI group weren't actually that impaired. So their scores were much more loaded towards the cut-off point. So it was a positive skew on the results. So therefore, in later research, we might try and see if we can try and get people who are at the more difficult end, or having more difficulties with SCI. But at the moment, in this participant group, they were not very impaired at all. But despite this, they were still showing slowing in reaction time, higher, more variable inter-individual variability, lower scores on mood, anxiety, quality of life, and memory, and higher scores on neuroticism. A major cautionary note that I wanted to add here. We did use the MOCA, which is a screening tool quite often used in primary care and in memory clinics, something, again, which I mentioned in a previous Age in Bite video. There were no significant relationships or differences between the two groups on MOCA scores. So therefore, it signals that, it just reiterates, really, that this test is not, or the mini mental status examination is the same as well. They are not sensitive enough to pick up those early changes, such as within SCI. Most of the time, these measures are used in primary care and sometimes used as a screening tool to be able to enter specialist memory clinics. Therefore, most of the time, when somebody only has SCI, if they are showing no changes on the MOCA score or their mini mental score, their SCI is dismissed and considered benign. However, in this study, we've noticed anxiety is a problem, depression is a problem, or low mood, neuroticism, and poorer quality of life. So surely we should be taking note of the fact that these measures are not sensitive enough for picking up these additional problems that we don't know yet if they are the cause or the consequence of SCI. However, there could be interventions to reverse those problems because they might be causing the SCI or the SCI might be causing those. Key messages that have come from this study then to finish off, that despite the cause, SCI should not be dismissed and considered benign. Screening measures such as the MOCA and a mini-mental status examination are not sensitive enough to pick up such subtle changes. There may be reversible causes of SCI, which could be targeted for treatment. Treating such causes could actually reduce the risk of developing further decline, as past research has shown that people who are more anxious and depressed might actually be more at risk of developing Alzheimer's disease at a later date. The next steps are to recruit more people and to follow them up. Obviously, this is a cross-sectional study. We need to do longitudinal studies to see whether or not this cause and effect has a pattern and whether or not people do decline into either having MCI or dementia. We would like to be able to introduce more measures on reaction time, stress, lifestyle and metacognition. And fundamentally, to raise awareness of the characteristics that we have identified with SCI, whether or not they are the cause or effect of cognitive impairment. Because these problems are reversible. Some of them are reversible and can really improve the future prospects of those experiencing it. If you have any further questions or are interested in the research that I'm carrying out, please contact me at Swansea University. Thank you very much.